Thank you. Today I have the pleasure of presenting findings from a quantitative phase of a rapid assessment and response of the harm reduction needs of people who inject drugs in Tanzania, in Dar es Salaam. Although heroin has been available in East Africa since the mid-1980s, it wasn't until the late 1990s that injecting drug use emerged as a concern in Tanzania, as the availability of white heroin led to a transition from smoking to injecting. Most recent estimates suggest that there are currently approximately 50,000 people who inject drugs in the country. Mainland Tanzania is characterised by a generalised HIV epidemic, spread primarily through heterosexual transmission. However, the few studies of people who inject drugs in Tanzania suggest that HIV prevalence in this population is substantially higher than the general population, particularly among women, where prevalence estimates have been as high as 65%, with high-risk injecting and sexual risk behaviours reported. There are currently no hepatitis C prevalence estimates for injecting drug users in Tanzania. Harm reduction interventions in Tanzania are scarce, and there has been little progress towards the scale-up of NSP or opioid substitution therapy. Beyond a recent pilot OST program at Muhimbili University Hospital and a recently established harm reduction program developed by Médicins du Monde. This program was established in 2010 in Temeke district, the poorest of 3 urban districts of Dar es Salaam and an area with a highly visible drug use. The program consists of NSP services delivered both through fixed site and through outreach distribution, HIV and hepatitis C voluntary counselling and testing, and HIV treatment and care services. The program was developed with a special focus on the service needs of women and was developed with the involvement of peers and the local community. To inform this program, MdM designed and conducted a rapid assessment and response that I'll report on today. The Burnet Institute provided technical and statistical support for the study. The objectives of the rapid assessment and response were to determine HIV and hepatitis C prevalence, assess knowledge of HIV status and access to HIV care, and describe risk behaviours amongst people who inject drugs and other drug users in Temeke district. And consistent with the basic tenets of a rapid assessment and response, it was also designed to inform an adapted operational response through the MdM Harm Reduction Program and inform broader policy in Tanzania. The rapid assessment and response consisted of 3 phases. First, a brief qualitative phase that was used to inform sampling strategies and questions for a quantitative survey phase that was accompanied by HIV and hepatitis C testing. A preliminary response phase included the provision of information and prevention materials to participants, and HIV and hepatitis C testing results and care and referral for HIV if needed. And today I'll be reporting on the quantitative phase of that rapid assessment and response. Participants were recruited through convenience, snowball and targeted sampling with the inclusion criteria of having injected any drugs in the past month, living in Temeke district, able to speak and understand Swahili and able to provide informed consent, including consent for HIV and hepatitis C testing. Data were collected face-to-face by trained field researchers with questions covering patterns of drug use, injecting and sexual risk behaviours, prevention and treatment service access, and HIV and hepatitis C knowledge. The survey was accompanied by rapid HIV antibody antigen testing and rapid hepatitis C antibody testing. 267 people were recruited to the study who reported recent injecting drug use. Participants were predominantly male with a median age of 30 years. In relation to injecting drug histories and patterns of drug use, the mean age of first injection was 24 years and the median duration of injecting among participants was 5 years. Daily injecting of heroin in the past month was almost universal in the cohort. More than 80% of participants reported first smoking heroin, with a median time to transition to injecting of 5 years. However, there was a trend towards more rapid transitioning among younger and more recent initiates, Those aged 25 years and under reported a median transition time between smoking and injecting of only 2 years, a result that I think underscores the growing urgency for the scale-up of local harm reduction and prevention programs. HIV prevalence in the group was largely consistent with the limited number of previous studies. The overall prevalence was 34.8%, about 30% for males, but substantially higher for females at 66.7%. Of particular concern was the high rate of undiagnosed HIV in the group. Over 70% of both males and females were previously undiagnosed prior to study participation. This is perhaps unsurprising, given that more than half of all participants reported no HIV testing history, more than 3/4 had not tested in the past 2 years, and 1/3 reported not knowing where to access HIV testing services. Hepatitis C antibody prevalence was 27.7% and consistent across gender. Almost all participants reported no hepatitis C testing history, and of the 8 that had been tested, 2 self-reported a previous positive result. HIV and hepatitis C antibody co-prevalence was 16.9%, while the actual co-infection prevalence will be somewhat lower when accounting for hepatitis C viral clearance. Likely increases in co-infection in this population will have substantial implications for comorbidity and liver-related burden of disease in coming years. While knowledge of HIV was very high in the group, only 1/3 had ever heard of hepatitis C. In relation to injecting risk practices, the sharing of needle and syringes with others was not commonly reported. The tendency instead was to report the personal reuse of needles and syringes, often after cleaning with water, with the proportion reporting reuse of needle and syringes similar regardless of HIV status. Where differences did emerge by HIV status was in the sharing of other injecting equipment, including a significantly higher proportion of participants reporting taking drug solution from a shared mixing container at last injection. The practice of communal sharing of a drug solution was facilitated by the locations where people inject and the social groups they injected with. In this study, about 1/3 of both HIV positive and negative participants reported their last injection was with a group in a camp or a maskani, a local term used to describe public spaces where people inject. Previous studies of drug use in Tanzania have also identified drug taking as common in these spaces, and the qualitative observations of the rapid assessment and response noted that nearly all drug users utilise communal public spaces to inject. Of concern is the significant association we found between communal injecting and other injecting risk practices, including the sharing of equipment and drug solutions. While these practices clearly enhance the risk of bloodborne virus transmission through injecting networks, these communal and social spaces also provide a fertile ground for adapted harm reduction responses. Which brings us to some of the key findings of the rapid assessment and their implications. First, it was clear in the context of high-frequency injecting and the common reuse of needle and syringes that local NSP coverage was inadequate and requires scale-up. In addition, in the light of the previous finding, such scale-up needs to include adapted distribution strategies beyond fixed site and include outreach and peer distribution alongside peer education. Second, high rates of undiagnosed HIV amongst participants means that harm reduction programs must also include voluntary counselling and testing services, including appropriate treatment and referral for HIV. While the provision of hepatitis C treatment for injectors should also be a key target of harm reduction programs, currently this is likely to be beyond local capacity and resources. Third, the extremely high HIV prevalence among female injectors supports a focus on services for women, including specific programs for women who engage in transactional sex work. Finally, the study provides an important advocacy tool for policy responses in Tanzania and the region in general, primarily in relation to highlighting the needs of people who inject drugs and the benefits of injecting drug harm reduction, both for drug users and the general community. In the study, we found that more than half of those with undiagnosed HIV reported unprotected sex in the past month, emphasising the potential for onward transmission to non-drug using populations. The potential future burden of liver disease in co-infected drug users also needs to be highlighted in harm reduction advocacy. I would like to finish by briefly detailing some of the recent reports of response outcomes from the MdM Harm Reduction Program. Field observations of people who inject drugs have indicated improved knowledge of bloodborne viruses and risk reduction, and improved hygiene and use of sterile syringes wherever possible. However, there remains an acknowledgement that NSP coverage still needs to be improved. Recently, 7 peer educators graduated through an MdM training program, and 1 is now working in a paid part-time position with MdM. And importantly, the concept of harm reduction has been planted in almost virgin territory. The model has been well accepted by local district authorities, and the MdM Harm Reduction Program model is now being promoted in other parts of Dar es Salaam and nationally. I actually feel extraordinarily privileged to have been able to work on this project and present to you today, but I should really only be seen as the messenger. The real acknowledgement needs to go to the MdM Harm Reduction Program team, the research team at MdM, the participants in the study, and the local Tanzanian partners who have supported the program. And finally, I'd like to leave you with this image, not only because I think it's a stunning photo, but it also represents some of the great work being conducted on the ground in Tanzania, in MdM. Thank you.